So, good evening, everyone. Thank you for joining us for this much anticipated monthly webinar on neuromonitoring in ICU. In this complex world of critical care, brain is often the silent battlefield. It is hidden behind sedation, ventilation, and life-sustaining interventions. Yet, what we don't see can often hurt the most. Neurological deterioration can be subtle, but rapid and irreversible if missed. In today's webinar, it is designed to shine a spotlight on the art and science of neuromonitoring. But first, we'll kick off by starting to talk about two essential topics that that make the foundation of neurocritical care. First is coma in ICU. We explore how to systematically approach an ICU patient with coma. And to talk about this topic, we have Dr. Lonnie Goswami with us, who is a senior consultant critical care in Apollo Multispeciality Hospitals, Kolkata. We welcome you, ma'am.
Hi, I'm Lonnie. Hello. Glad to be here. Glad to be a part of this. Should I start?
Yes, ma'am.
Right. Okay. Thank you. I'm glad to be here. Thank you for having me in this webinar. And we start off with an approach to coma. It is a difficult topic because when a patient comes in and he's unarousable, it's only a very structured approach which can actually get us to the diagnosis and to help him, the patient, in getting out of the doldrums that the patient is in. In order to know this, we need to first find out what is the consciousness, because it is always essential to know the known before we go to the unknown. So consciousness is a state of full awareness of the self and its relationship with the environment, and consists of two basic things, which is content, which is the cognitive and effective responses of the patient to the environment, and arousal, which defines consciousness. So unconsciousness actually, or unresponsiveness, is when a patient is said to be comatose, which is derived from the Greek word saying deep sleep or trance, which is a state of unresponsiveness when the patient lies with the eyes closed and cannot be aroused even after appropriate stimuli. Earlier, we would say about the altered mental status being varying between a patient who is drowsy, obtunded to stuporous, and it's only when he is absolutely unarousable and there is no meaningful response that the patient is said to be comatose. And this can, the various stages of the sensorium can vary from a person being, as I said, in coma, who is not arousable, not aware, to a patient in a locked-in syndrome who's both arousable and aware and would be able to perhaps respond by blinking of the eyelids. The vegetative state, where the patient has some amount of awareness but is not arousable, and the minimally conscious state, where the patient would have variable amounts of both arousal and awareness. Now, let's take a peek into the neuroanatomy. We know the reticular activating system is where the sensorium or the responsiveness or the consciousness arises. And this system arises in the upper pontine tegmentum rostrally. So it is in the rostral area, in the midbrain and pons. It goes up to the thalamus and the anterior cingulate gyrus, and then it dissipates to bilateral hemispheres. It is essential that we know a little bit of the neuroanatomy, because this would help us to pinpoint as to the lesion that the patient has if he is comatose. Regarding the neurotransmitters that could be there are various neurotransmitters, and it is again essential that we know which are the neurotransmitters which keep us awake. For example, my father, who was getting dementic and getting more and more stuporous, did remarkably well when he was put on an Axedon patch, which had acetylcholine as the molecule that was released because of use of this patch. So this is again a very, very common MCQ question which comes in, so would be of value to know about these neurotransmitters by all the students. Consciousness would vanish, or the patient would be in coma, therefore, if there is a lesion, say, in the dorsolateral upper mid-pontine area, where the reticular activating system is extremely dense. So any tiny pontine infarct or a pontine hemorrhage will result in a loss of consciousness. It could also occur because of paramedian upper midbrain injuries, diencephalic injuries, or the hemispheric injury will have to be a diffuse hemispheric damage. One small hemorrhage in either the cerebral cortex usually do not cause loss of consciousness. the causes are mild, right? And in fact, there is a whole book, the Pullman Posner's Diagnosis of Stupor and Coma, which gives you all the good 300, 400 pages of diagnosis of the comatose patient. But a structured approach really gets us into the actual diagnosis. In fact, as it is said, coma is a situation where the family members are obviously distressed, the physician is challenged and equally distressed, but it's only the comatose patient who doesn't have any anxiety and he's nice and merry and asleep. So let's start with a case. This is a 66-year-old retired school teacher who lives alone, non-diabetic, hypertensive, had a pacemaker placed about 2 years ago. He's brought to the ER because his household help, who went in at 9 o'clock, found that he didn't open the door, and went in again at around 1 o'clock and found that he still didn't open the door, alerted the neighbors, who informed the police. The door was broken open and he was found unresponsive in his bed. He was then taken to a nearby primary care center. His last contact was with his daughter over phone around 11 p.m. the previous night. So the neighbors take him to a center, they give him some treatment, and then by then the family arrives and brings him to our hospital. This was about 2 Sundays ago, and this patient arrives in our setup around 1 o'clock in the afternoon. He has a GCS of 3. His pupils are equal and reacting. His plantars are bilateral extensor. His vitals show 60 beats per minute, which are all paced beats. His BP is 160/70, is about 99.8 degrees Fahrenheit axillary temperature, and his respiration was described by the ER physician as extremely labored. He's immediately intubated and ventilated. The sugar that was checked showed 130 milligrams per DL. Post-intubation, they did an ABG, which did not show any acid-base disturbances, and sodium and calcium, which are the common electrolytes which causes coma, were within normal limits. The tox screen, which was also done, was negative. Now, how do we approach a patient who comes in like this? Yes, of course, we take a history, which obviously the patient cannot give because he's comatose, but the history should be obtained from relatives, friends, or attendants. We need to find out about the onset of coma, which was abrupt, which would indicate that it was a vascular lesion, probably a massive CVA. If it is gradual, it could be a slow-growing tumor, which is now expanded so much that it has caused coma, and a fluctuating sensorium would indicate towards a person who probably has an acute and chronic SDH, or it could be because the patient has had seizures before and now is in status. Recent complaints of headache, depression, and focal weakness are to be looked into. Previous medical illnesses also give us a clue as to the state of the comatose state now, because a patient, for instance, if he had a CLD, could probably be in a hepatic encephalopathy at this moment and could be in deep coma. Previous psychiatry history and access to drugs are also essential. Now, our patient did not have any of these. He was not on any DOACs or any psychiatric medicines. Then again, it is very important that we take a history about DOACs, because now a lot of our patients are on them and do come into the comatose because of a diffuse bihemispheric bleed as well. Now, while this history is being taken, there should be the nurses who are at the bedside trying to put in the IV lines, checking the sugar, which is again a very important thing to be checked, hooking onto the monitors, giving oxygen, drawing out samples for the labs, the basic labs of a complete metabolic profile, including sodium, potassium, sodium, and especially sodium and calcium, which are the main electrolytes, which imbalances can cause coma. And it is important that we immobilize the spine if trauma is suspected. At the same time as this, while we are assessing the vital signs, if a patient has tachycardia, it could point towards intoxications by sympathomimetic drugs, or it could be just acute structural brain injury, which is causing tachycardia. Bradycardia could mean intoxications by beta blockers, by calcium channel blockers, or it could be a part of the raised ICP, the famous Cushing syndrome, or it could be because the patient is in a mixed edema coma. Extreme hypertension would indicate as a PRESS, which is where it shows that it is an encephalopathy that is present, hypertensive bleeds, or as a part of the Cushing syndrome, as I mentioned, when extreme hypertension is associated with bradycardia. A patient could be hypotensive because of circulatory failure, because of certain drugs, or Addison's disease, and hyperthermia could point towards an NMS, a serotonin syndrome, or a massive pontine hemorrhage. Hypothermia could be accidental, or it could be just that the patient was under influence of a lot of ethanol, and or it could be because of a distributive shock, either because of a spinal cord injury or because of a circulatory failure because of a septic condition. Now, the evidence of trauma needs to be looked into, because these patients not only need the cervical collar, but then if he's comatose, he needs an urgent neuroimaging and perhaps a neurosurgery, because it could well be an extradural hemorrhage, which is causing the trauma. Evidence of acute or chronic systemic illnesses, and of course, drug injection are also to be looked into. Now, nuchal rigidity is to be looked at, because that would point towards an infection, and infections of the CNS really need to be treated ASAP, because they would do very badly if you don't have the antimicrobials in as quickly as possible. The neurological examination of these comatose patients are actually pretty simple, unlike the detailed neurological examinations which are done in an OPD patient, because we just need to look at the respiration, the pupils, the reflexes, and the motor response. To start with, we have a number of scores, of which GCS is the time-tested score, where we look at the eye response, verbal response, and motor response. And depending on whether the where the patient stands, a severe injury, a traumatic brain injury, or severe state of coma is when the patient's GCS is between 3 and 8. And remember, 3 is the least score that the patient can have. And the number 8 somehow seems to be, kind of etched in our minds, because we all are taught that if the patient's GCS is less than 8, he perhaps will not be able to maintain the airway and would need an airway to be placed. The other score that we are now getting more and more into assessing nowadays is the 4 score, which, apart from the eye response and motor response, also puts in the brainstem reflexes and the respiration as one of the things that we need to document. And this is more of value in patients who are on the ventilator, because it gives a more detailed description of the score. The more easy score, especially for a bedside nurse, would perhaps be the AVPU score, which is whether the patient is alert, can be arousable to verbal stimuli, pain, or unresponsive, and the ACDU score, which is alert, conscious, drowsy, and unresponsive. As we all start with, the ABCs, the airway having been taken care of in our patient because his GCS was so low. The next comes the breathing. This is actually becomes redundant because we've already intubated the patient, but otherwise a Cheyne-Stokes respiration, which is the rhythmic respiration, can be seen in patients with lesions of the forebrain or in metabolic causes. But I think most of us would just describe this breathing as a labored respiration, because we really do not have the time to kind of pinpoint as to whether the patient really has a hyperventilation or apneusis. So it would be okay if the ER physician then just says that the patient's had a labored respiration and goes ahead and protects the airway. Next comes the motor response. The motor response can be seen by giving adequate pain, which would be either in the supraorbital region, in the nail bed, above the sternum, or laterally in the temporomandibular joints. And we need to then identify abnormal motor patterns. For example, in this, if you see, we have a patient here who is perhaps localizing the pain with his right hand, but his left arm and his left foot there is no response. The left foot is externally rotated with the extensor plantar response. This indicates that the lesion is probably in the forebrain of the diencephalic lesion, or it's a diencephalic lesion, as compared to the patient who has a decorticate posturing, which is flexion of the upper limbs and an extension of the lower limbs, will point towards a lesion in the junction of the diencephalon and brain. And as it moves further, the patient would go into a decerebrate posturing, which is extensor posturing of both the upper and the lower limbs, indicating that the lesion is in the midbrain. The examination of the pupils is a very important examination that we need to do. And all of us, we know, are afraid of this unequal pupils, of which one is dilated, indicating that there is some amount of uncal herniation, and the pinpoint pupils, which are seen in patients with a pontine hemorrhage. There are certain the gaze abnormalities which can be seen. For example, if there is a cortical damage, the eyes deviate towards the lesion. A skew deviation where one eye looks upward and the other downward would be a pointer towards a basilar artery occlusion, which is one diagnosis which certainly do not want to miss. A patient would have a downward gaze if there is bilateral hemispheric dysfunction or thalamic injury. Focal seizures causes the gaze to get towards the size of the seizing limb. An upward gaze, which is perhaps the most terrifying gaze that is seen, because it indicates that there has been bihemispheric damage, most probably because of an oxic injury, and is almost a prognostic finding in a patient who is in a neurologically poor state post cardiac arrest. Can also occur in seizures. And horizontal conjugate roving eye movements could happen because of bilateral cerebral hemispheric dysfunction, either because of toxic metabolic coma or severe bilateral hemispheric infarction. Now, going back to our patient, he was certainly not feigning it, because a person who is feigning the coma will not let you open the eyes. This patient's eyes can be opened, but they close immediately. And when we kept the eyes open, we found that he has a to and fro movement. If you notice this video, his eyes are moving to and fro, which is known as the classical sign of a roving eye movement. This indicates bihemispheric, metabolic, or various toxicities that causes this roving eye movement, and it is a clear indicator that the brainstem is relatively intact. The next reflex that we need to see is the corneal reflex, which was classically seen by a wisp of cotton, which is taken over the started from the sclera and goes over to the cornea. But as the wisp of cotton may cause injury, we can now test it by instilling a drop of saline. And the afferent over here is the ophthalmic division of the trigeminal, the efferent being the facial nerve. And this, again, absent corneal reflexes, especially 24 hours after the cardiac arrest, is usually, but not invariably, an indication of poor prognosis. The next the reflex that we can see is what is known as the oculocephalic or the doll's eye test, where a comatose patient's head is rotated from side to side. And an intact response would mean that the eyes that consist of the contralateral eye movements back. Initially, in an intact response, the eyes would move towards the side of the lesion and then it would come back. And this would of the doll's eye reflex means that the brainstem is intact, or if there is a toxic metabolic encephalopathy, and absence obviously means that the brainstem is not present. But in a patient who is perhaps feigning his coma, the doll's eye reflex can be absent because the patient is able to keep the gaze. And then we are able to test it further by doing the cold calorie test, where we instill water into one of the eyes. And on doing this, there would be the normal response will be an ipsilateral gaze deviation, followed by the gaze coming back to the midline. And this would be the normal response. And even if a person is feigning his coma and is a psychogenic coma patient, they are usually not able to, this is a reflex that will happen because the reflex happens because of the cold water that is placed, causes the abducens nerve on that side to not react, which is why the eyes would then turn to that side and then slowly come back to normal. So if you look at the pathophysiology going so far, there has to be either a global acute physiological derangement of the brain function, or there has to be a structural lesion. In the structural lesion, it has to be either bihemispheric, which is rather uncommon, or there would be a brainstem lesion, which would be an intrinsic brainstem lesion, or a secondary brainstem injury because the the lesion, which like a bleed in the, like, be it a subdural or even or an intracerebral hemorrhage, which has now caused a herniation. And the herniation could be either subfalcine, central, uncal, or tonsillar. And we are all scared about these herniations because that becomes a neuroemergency requiring a urgent neurosurgical procedure. The way we can find out about these lesions is by doing a CT scan, where the mass lesions or the bleeds or the infarcts are very readily seen. And these could be the reason why the patient is getting, is in the comatose state that the patient is in. Now, if it is an ICP or an ICP crisis situation, it entails normal neurocritical care of putting the head end up and cerebral edema management by using 3% or hypertonic saline or mannitol, or it could entail that the patient gets a neurosurgical review for a decompressive craniotomy or an EVD in order to create space. As we know, with going back at our physiology, we know about the Monroe-Kelly doctrine, and we know that something has to be done now in order to give space for the expanding brain. Now, going back to our patient, a code stroke is called. A CT brain is done, which does not show any acute lesion. The patient is put on ceftriaxone, vancomycin, acyclovir, and some levetiracetam. A CSF study is done. The LP is done at the ER. And then the patient gets shifted to the ICU about 4 hours after arrival to ER. The nurse in the ICU checks the blood sugar, and finds that it is low. And an ABG done at the same time shows a blood sugar of 18 milligram per TL. He is immediately given some thiamine, and 50% dextrose infusion is started, which is followed up by a DNS in order with a hourly blood sugar monitoring to check the to maintain the blood sugars. The daughter now comes in, and she says that he had boasted about a new diet regimen that he was trying, that the patient had boasted about this new diet regimen. He kept on taking his anti-diabetic medications. And so the reason for him to be in coma is probably because of a neurohypoglycemic situation. A neurologist is called, and he asks us to do an EEG, which shows generalized asynchronous reactive delta range activity intermixed with triphasic sharp waves, suggestive of global cerebral dysfunction, likely toxic metabolic origin. And to complete the array of diagnostic parameters that we need to know, we went ahead and did an MRI also of the brain. Why do we do the MRI? Because subcortical and cortical lesions are sometimes better picked up in the MRI rather than in the CT scan. And in fact, pontine on an extrapontine myelinosis, which could be the reason why a patient is coma because of the sodium abnormalities, it's again more easier picked up in an MRI than in a CT scan. MRI could also be helpful in the viral encephalitis patterns, where there would be lesions in the thalamus and in the frontal lesions in herpes simplex encephalitis. So the whole array of diagnostic tests that were done for this patient. And yes, we went ahead and did an MRI, which showed symmetric diffusion restriction in bilateral cerebral hemispheric white matter and splenium of corpus callosum, what is known as the bright tree appearance, suggestive of acute leukoencephalopathy with restricted diffusion, the possible etiology being toxic metabolic syndrome. Now the family comes back and asks, what next? What now? So it is very essential that at the outset, we identify the family member with whom we are going to communicate, because there would be 7, 8 people who are trying to come in for this patient, and it actually proved to be very difficult till we said that we are going to talk to the son-in-law. So it is very essential that we identify the family person. The initial prognosis is uncertain, so we should not be giving them deadlines, but saying that we're going to check for 72 hours, because we need to give them full intensive care therapy for the first 24 to 72 hours. And then we need to neuroprognosticate, which is a difficult proposition, because we don't know where the trajectory will be in terms of the neurological status of the patient. Because there was this JAMA paper which came out last year, which said that although there are emergent techniques They are not yet perfected, but they are too promising to ignore. But no matter how much prognostic markers evolve and improve, these assessments must be approached with humility and individualized to reflect each patient's values. So each person on his own, each person needs to be individualized. Individualized cares must be given. And it is very essential to do neuroprognostication because the logistics of taking care of this comatose patient rests, after all, in the family, and we need to be true to in our words. So the causes of coma are myriad, and this would be perhaps a easy acronym to remember, and a structured approach normally gets us to get to the diagnosis. With that, I would like to thank my presentation. Thank you.
Thank you so much, ma'am. It was very structured and informative. I did not know coma could be so interesting also. Thank you so much for enlightening us with that. So with that, we'll be moving to our second talk, which will be approach to a patient of delirium in ICU, delirium, which is a silent pandemic in ICU. So to deliver that talk, we have Dr. Raymond Savio with us, who works as a lead consultant in critical care services in Apollo Proton Cancer Center, Chennai. We are really glad to have you, sir. Thank you for joining us. Over to you.
Yes. Is my slide seen?
Not yet.
No? Oops. Nice. Please hang on. Yes?
Yeah, I think it's loading. Yeah.
Right. Just. Okay.
Just make it full screen. Yeah, perfect. Thank you.
Yeah, it's full screen?
Yeah.
Great. So, yeah, good evening, everyone. And we could be running out of time, so let me quickly get into business. Delirium in ICU is not something that you are not familiar with. I'm sure everyone will agree with me that it is very common in all of our ICUs. Let's save up on some time talking about the epidemiology and all that. It's understood that it is underdiagnosed. In fact, it's not just us. There are global surveys that clearly tell us that everyone agrees that it is common, but less than 50% of the ICUs actually proactively screen for the presence of delirium. Is it necessary, or how important it is that you aggressively screen at every shift? That depends on your cohort, because the whole importance lies on the fact that it is going to increase morbidity, it's going to increase mortality, it's just going to prolong stays and add on to too many problems like any other potential complication in the ICU. So before we move on, a quick word of caution. Is ICU psychosis the same as delirium? Because quite often we tend to, unfortunately, mix and match these two terms. They both are not one and the same. Remember that delirium is a very, very distinct, characteristic, defined neurobehavioral syndrome, okay, which is characterized by neurotransmitter dysfunction. It is very clearly defined. We have diagnostic criteria by the DSM manual. Unlike psychosis, which is more towards a psychiatric side of the spectrum, which involves more of hallucinations, delusions, it's a completely disorganized process. So these two are not one and the same. Because we could be quickly rushing over the subsequent slides, I put up these two useful reviews, 24 and 23 reviews. Somebody who wants to go back and read up, very welcome. These were nice. Okay, so who is at potential risk for developing delirium in the ICU? Of course, you see a beautiful big list out here, but trust me, anyone who potentially lands up within the four walls of ICU is at a significant risk for developing. delirium. Classically, we classify as non-modifiable and modifiable factors. Obviously, you can't do much about that list of non-modifiable factors. You can see over there, there's a big list. Let's not waste time on that. Where you and I, as intensivists, come in is when the risk factor is potentially modifiable. Look at that, functional impairment. That's where we keep talking more and more these days about early mobilization. Sensory impairment, which is very common in our ICUs. Please make it a point to go and look for whether the patient needs or is used to using glasses or needs auditory aids. Likewise, there are a few other things that you can smartly control: duration of anesthesia, alcohol, malnutrition, blood loss. In case it's a complex perioperative procedure, that's where prehabilitation really comes in. You need to really factor in all these things such that you preempt delirium and you prevent delirium. Similarly, under the completely modifiable factors, I think there's a big list, but ultimately everything revolves around being able to mitigate patient discomfort. Let's focus our care on patient comfort and reduce the chances of developing delirium because of any of these factors. And yes, there are a whole lot of these medication which we almost always use in all of our patients almost all the times, which are all supposed to be high risk medication for subsequent delirium. We cannot do away with these, but be smart. Always have a drug and target sort of an approach. Titrate sedation, titrate the use of opioids. Always go by established and validated scores. Try to use the least dose possible. Always promote daily sedation interruption. There are so much that you can do in this regard. Okay. So all this so that you don't land up with this triad. Everybody starts off with pain and agitation, but once there is delirium also completing the triad, it becomes a vicious process and it becomes an utter mess up. So you can really intervene at the level of pain and agitation. Yes, the pathophysiology is a lot complex, but I'm not going to be dwelling into that. Whatever the etiology be, infection or drug-induced stress or whatsoever it is, the bottom line is there is some kind of a neurotransmitter dysfunction, and quite often dopamine and acetylcholine are what are implicated in the pathogenesis of delirium. There are various other things also that people have researched about, like GABA, serotonin, endorphins. And based on these neurotransmitters, they are also in the process of trying to find plausible biomarkers, blood biomarkers that can tell us that this is delirium, but we are far away from all that. Okay, so there is neurotransmitter dysfunction. And yeah, I already told you this is a very specific defined entity. The definition criteria is given by the Diagnostic and Statistic Manual by the American Psychiatry Association, along with the ICD coding system. We have the 5th edition. I've tried to, so Madam Lonnie had already spoken about consciousness, arousal, and all those things. So I'll not go into that, but I've just tried to put the spectrum over there. This was already discussed in the previous talk. And I've tried to point out where delirium lies in the spectrum of problems with arousal and attention. Obviously, when somebody has a RAS of -4 or -5, it cannot be delirium. Okay, that is more of coma or a brainstem dysfunction sort of a thing. You need to have somebody with a RAS of at least -3 to all the way to +4. Okay, this is where the spectrum of delirium lies. And we diagnose delirium using these 5 domains as put across by the DSM-5 recommendation. Number 1, there should be a disturbance in attention and awareness. There should be a recent onset nature with possibly a diurnal fluctuation. There may be additional cognitive disturbances. And based on history, physicals, you need to be able to diagnose or exclude other diagnoses. And history always needs to be a surrogate to, bring in other possibilities of similar past episodes or the presence of neurobehavioral abnormalities in the family, use of medication, especially long-term use of benzodiazepines. Alprazolam is a big culprit out there. Withdrawal could be a real big challenge. Likewise, any other lab evidences which could corroborate with the possibility of a delirium. Now, how do we conceptualize these 5 domains in the bedside? I'll show you in my subsequent slides. Quickly, yes, there are subtypes. While hyperactive form is very, very easy to diagnose, that forms the smallest chunk of our patients in the ICU. quite often we see the hypoactive, which is also known as the algid delirium, or the mixed variant. Okay. Now, these numbers that I've put out over here come from the AID ICU Inception cohort, which is one of the large delirium cohort studies that have happened relatively recently. So using how do we implement or how do we conceptualize the 5 domains? Of course, the first 3, there are tools for screening and diagnosis in the bedside. I've put out a big list of them, but don't worry, you don't have to bother knowing all of them. Based on, like, validation and evidence weighting, also based on the quality of psychometric analysis, the PAD guidelines 2013, PAD expanded as Pain, Agitation and Delirium Guidelines 2013 is a second amendment that came up, recommends that we in the ICU use either the CAM ICU or the ICDSE. Okay, CAM ICU is basically confusion assessment method for the ICU, and the other one is the intensive care delirium screening checklist. These two have been shown to be very good in terms of quality of analysis and for the diagnosis of delirium in ICU. All right. Now, of course, I'm not going to be demonstrating or teaching you how to do CAM ICU. I assume that you all know. Even otherwise, I strongly recommend that you go back and look into one of the YouTube videos that are there. Very good videos are available for practicing CAM ICU. Please learn and make sure you do them in all of your patients who have subtle fluctuations in sensorium. So this basically has 3 or 4 components wherein we assess for fluctuating or a change in mental status. We look for inattention, we look for an altered level of consciousness and disorganized thinking by very simple maneuvers, and we find them to be CAM ICU positive or negative. Positive is where you say that the person is having delirium. You need to, of course, support this along with history, physical, and evaluation, like we already spoke about. Okay, it is a diagnosis of exclusion. We need to rule out all the other significant encephalopathies. Alternatively, you can also use ICDSE in the ICU if you are capable of remembering the 8 components. Each one carries a score. So ICDSE also comes up with a numeric rating. So it gives you a score which helps you to follow the patient serially. Okay, a score more than 3. 1 point is allotted for each one of these components. A score more than 3 is considered to be diagnostic of delirium, again supported by diagnosis of exclusion and history physicals. Okay. This also introduces the concept of subsyndromal delirium, which is not delirium, but something like, I would say, a pre-diabetes and diabetes, something like that. So you get a lot more watchful if you fit into the subsyndromal category. Very recently, there is this newer addition to CAM ICU that came up called the CAM ICU 7, which is nothing but a validated grade that gets added to the same existing CAM ICU. This also introduces a numeric rating of delirium, so you get to follow your patients on a serial basis, or this also comes in handy for research purposes. Okay, this also gives in the subsyndromal component. Please go and read up about this. This came up somewhere in 2017-18, and it's reasonably validated with small trials. So once you have a patient diagnosed to be having delirium with one of these scores, we of course have to exclude all other possibilities. Quite often in the ICU, it is a septic encephalopathy, isn't it? So you rule out all those forms of encephalopathies, septic encephalopathies, metabolic encephalopathies, notably electrolyte related or ammonia related and things like that, intoxications, withdrawals. Also more important will be to rule out neurovascular insults, a new onset stroke and things like that. Vitamin deficiencies, trace element deficiencies are also important factors, especially in someone who is malnourished. In my ICU, where I deal with a lot of malignancies, GI malignancies, quite often we see encephalopathies related to vitamin B1 deficiency. Vitamin D deficiencies also can present with significant encephalopathy. And of course, endocrinopathies, hypothyroidism, the big mimic, for so many disorders. So all that goes on. It's very easy to prevent rather than try and treat. There are so many bundles that exist. I would recommend you to go and look up at this ABCDAEF bundle. Basically, assess, prevent, and manage pain. Use SAT, SBT every day. include DSI, choice of analgesedation, try to avoid benzodiazepines, have a rational use, titrate them. Delirium assessment, ideally to be done once every shift assessment. Early mobility and exercise, we keep talking a lot about that these days. And family engagement is foremost. Nowadays, we want families to participate in care, to participate in rounds. That comes a long way in reducing delirium occurrence. Once you diagnose somebody to have delirium, of course, you have choices between non-pharmacological and pharmacological management. Non-pharmacological management, I think most of it we have already discussed, providing orientation therapies, mobilizing, reducing agitation. Try to, optimize whatever you think is adding on to patient distress. That's very, very important. And this should be the first line approach to handling patients with delirium. Pharmacological management, you are all experts. Our choices are between antipsychotics and non-psychotics. Again, among the non-psychotics, dexmedetomidine has become our reasonably favorite drug. A lot of us use that in and out. So that's a good choice. I would just like to point out to one new addition that has come up, that is melatonin, which has a reasonably strong level of recommendation in the most recent PAD guidelines. I'll just quickly show you to kind of orient the day-night cycles. Among the antipsychotics, of course, between typical and atypical, all these agents that you see can be used. They are reasonably safe, but these should not be the first-line drug of therapy unless the patient is at risk of harm or utmost distress and difficult to handle. Okay, it involves a lot of precautions in terms of preempting cardiac arrhythmias. They could land up with extrapyramidal syndromes, rarely NMS. All these things, drug interactions are all there. So you need to be aware of that when you resort to pharmacological management. This is something, I'm almost done. This is something you all need to go back and read. It's an enormous document. It's not going to be possible to, read out all of this. It's called the PADIS guidelines, basically pain, agitation, sedation, delirium, immobility, and sleep disruption in adult guidelines. That came up in 2018, which talks about each one of these questions and gives a nice rationale and literature review. Kindly go back and read this. It's available as open access. And most recently this year, we have another focus update that came up with just 5 additional recommendations wherein they revise some of their previous strategies. So please go and read up. In good interest of time, let me just skip that. We are all aware that delirium occurrence is associated with short-term and long-term outcomes. So be very watchful, be proactive, monitor them at least every shift. And of course, the future seems to be brilliant. We keep talking about so many things, newer ICU designs, the role of artificial intelligence, and you can see a big list of things in the pipeline over here, which all are quite captivating, but we are no more there, not yet there. But let's hope with all this in the pipeline, our outlook for delirium is better. We start identifying patients better, or we start preventing them better. And in the long run, really make a difference to the standard of care in ICU. Thank you, everyone.
Thank you, Dr. Raymond. I think it was very enlightening, especially the evidence-based practices and the latest updates. Now, thank you for finishing on time also. Now we can quickly break for the panel discussion. To moderate this panel, it gives me immense pleasure to introduce Subham, who is lead and senior consultant critical care in Apollo Multispeciality Hospitals, Kolkata. He is American board certified in internal medicine, pulmonary medicine, and neurocritical care. In our panel, we have esteemed panelists. We have Dr. Prashant Kumar, sir, who is the president of SNCC. He is the head of neuroanesthesia and critical care at University of PGIMS, University of Health Sciences, Rohtak. Dr. Subba Reddy, sir, who is a senior consultant and Department of Critical Care, Apollo Health City, Hyderabad. Dr. Swagata Tripathi, who is a professor and head of ICU Department of Anesthesia and Critical Care in AIIMS, Bhubaneswar. And we also have Dr. Keshav Goel with us, who is a professor in AIIMS, Delhi, and he works in of neuroanesthesia and critical care. We welcome you all. Over to you, Dr. Suresh.
Hi, thanks, Mona. Can you hear me? And can this slide be
Yes,
seen?
sir.
Alrighty.
Yes,
It's
sir.
a wonderful panel. I think we had wonderful talks on the management of approach to coma, approach to delirium. So obviously there is the neurocritical care. I think we have some of the stalwarts here. We understand the initial emphasis for most of the critical care students is to diagnose stroke, diagnose and manage that, give thrombolysis or diagnose meningitis. But eventually in the ICU, the focus shifts to secondary processes and it requires monitoring. And that's something which we do. And the term that is nowadays mentioned is multimodal monitoring, because we realize that one thing doesn't help. And we have an entire panel which is going to discuss about this whole concept of how to go. And the point is that the traditional monitoring is the standard ICU monitoring is pupil and neuro checks. We know it's like most of the results are after the horse is bolted out of the barn. We shut the barn door after that. So we really need to go ahead of that times. And so therefore we have an esteemed panel of people who are actually doing neurocritical care and who are actually using some of these things and who know what is multimodal monitoring and do understand that we want to delay early, want to detect early the neurological warnings, the individualized patient care decisions, and do all the good things so that the patients can have a better outcome, especially with catastrophic illness. All right, so I'm going to put this up like this. So this is the monitoring modalities that we have. So there are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Out of that, I think the last four, we probably will leave it because cerebral metabolism, and other than Keshav, probably nobody else does it, or probably Swagata does a little bit of cerebral microdialysis, but otherwise we are probably not going to speak on that. So let's look at neuromonitoring and say clinical evaluation. I'll request Dr. Prashant to start and say, look at these questions, and these are the questions that we ask in the Viva, and say, should we have heard Lonnie ma'am present about 4 scores about GCS, and we heard ICU CAM scores. So what is your opinion in neuromonitoring? Where do we stand with all these tools? What are reliable, what is not reliable? How do we proceed, Prashant?
Now, very good evening, everyone, and thank you, Dr. Suresh, for taking things in a wonderful way in terms that we are going so systematic. I'm so happy that you brought the clinical evaluation first, because what is happening, fortunately, in the newer world of coming up with the more and more of the technology, more and more of the newer tools coming up for us in the ICU for detection or the assessment. Somewhere we have started losing the track for the clinical evaluation, and the importance is going down. So I really congratulate everyone that you are on the right track now, that when we start looking at any of the acute brain injury, or we are trying to prevent the secondary brain injury, clinical neurological examination still holds a fundamental component as the first key to successful management of any neurologically deteriorating patient. Now, what we need, Dr. Lonnie said, Dr. Raymond said, what are we assessing? So first assessment is awareness. So we need to know degree of awareness. And for that, what we need is clinical tool. Unless we suspect clinically that there is some change in degree, we cannot go for any quantification. The tools will give us quantification, but our first suspicion will come from clinical assessment. So which tool to use? See, it depends on your situation, depends on your patient. But yes, what is the most commonly used is Glasgow Coma Scale. The only thing which troubles with the Glasgow Coma Scale that we do not include the pupillary light or the corneal reflex with it. So these are the essential part. If you are using GCS, what we talk in ICU, we talk in ICU of GCS. And as soon as we know the GCS, madam said here that if it is 8, no, it is severe. So we need to know what severity we are going. We need to know whether we have just a trivial injury or a severe damage. So GCS is there. But if we include that we need to have assessment for the pupillary light reflex, so probably you can easily practice about full outline of unresponsive, that is 4 response. Then Dr. Raymond has very beautifully taken us towards the very important aspect of delirium. So confusion and delirium, they also need to be assessed, and when they can be suspected only with the clinical score when we either use a CAM ICU or you go ICU DSC. So all these assessment tools are there. They are very handy. Once you start practicing, you do not find them difficult to use, but they will remain the essential tool. What I will add, just one more thing in 15 seconds, that for the neurological examination, also please include the neck stiffness and motor responses. Go for the plantar and deep tendon as well. So these will also give us little assessment for the which part of brain we are going to look for.
Dr. Prashant, thank you very much for re-emphasizing. And a daily neurological examination in the neurocritical care is mandatory. Motor response, everything, a daily neurological examination is absolutely essential while working in the ICU. When we talk about the pupils, Dr. Keshav, any experience, because this is really coming up of automated pupillometry. Any one of us using this, and what's the opinion, Dr. Keshav? I'll start with you on this, because when you're looking at neurological examination.
Thank you, Dr. Suresh and the ISCCM for giving me this opportunity. Regarding the pupillary examination, as said by Dr. Prashant already, the clinical examination is the gold standard. It has to be done, and then you can add up with other monitoring part. So that is a gold standard that has to be done. And it comprises of three things. That is the GCS or 4-score, then pupillary examination, and then lateralizing signs. So pupillary examination forms a very important part of the clinical examination. And what we have been doing till now, we have been doing subjectively. NSSRL, NSRL, normal size, sluggishly reacting, or whatever the nurse is writing, and got very subjective. But now we have the objective parameters by which we can measure the pupil size, their reactivity to the limit of 0.1 millimeter. Even this can be read till the 0.1 millimeter. So that objectivity and the real trend following, which is so important in basically neurocritical care monitoring, has come up in the form of automated pupillometry, which is available with the two. Basically, it is a Neurolite and a NeuroOptic. This is available, and you can measure the size, you can measure the constriction velocity, you can measure the dilation velocity, and also the NPI and QPI indexes are given. So a lot of information is given by them, and you can non-invasively measure the ICP as well from these monitors.
Absolutely. I think very well said. I think the objectivity is the measure, and I think we have to be a little bit more objective. So it is important. Dr. Subbareddy, we all practice general critical care. So this is a question that comes up is, what is the hemodynamic monitoring we do? We all have our neurocritical care patients, but they're also hypotensive. And what do you do? What tools? Because this is something which is neglected in neuromonitoring. If you don't have a good perfusion pressure, you're going to die. Your brain is also going to die. So how do we do that?
Yeah. First of all, good evening all, and thanks to Suresh sir and ISCCM for including me in this excellent panel discussion. Yes, as you rightly said, the hemodynamic monitoring, even the advanced hemodynamic monitoring, is generally neglected in the neurointensive care. That may be because of the lack of knowledge, and then the people who are managing the neurointensive care in some places, because some places the neurointensivists, some places the neurologists, neurosurgeons, they monitor. But if you see the multimodal neuromonitoring, like all these high-end technology, cerebral microdialysis and ICP monitoring may not be available, but the simple thing is good hemodynamic monitoring is available in most of the ICUs. So routinely, when you have a severe traumatic brain injury patient or any acute brain injury patient, it is mandatory to put invasive arterial line and then monitor the invasive arterial pressures, because so you may not be monitoring the ICP, but you have to monitor the mean arterial pressures. That is most important. And in some patients where traumatic brain injury with polytrauma, where there is a hemodynamically patient is very unstable, or sometimes the neuro patient may develop sepsis and septic shock. So there you have to find out whether it is distributive shock or is there any hypovolemic shock, and what is the volume status of the patient. So there in few patients, sometimes we may go for cardiac output monitor, sometimes maybe invasive or non-invasive cardiac output monitor. But in general, the regular like hemodynamic monitoring is required to maintain good cerebral flow and oxygenation to prevent cerebral ischemia. This is mandatory.
Absolutely. So I think very well said. Maintaining a good map is the number one thing, and an invasive ABP monitoring in all unstable or at-risk patients in the ICU is probably the best thing we can do, because that's our expertise that we have acquired over this thing. Moving on to the monitoring of actually the intracranial pressures and the cerebral perfusion pressure, which is MAP minus the ICP. So Dr. Swagata, you do a lot of things, and I'm going to again put a few questions up to you and say, where do we stand in a developing country, even in a, or we say resource limited country? Some of us like us in Apollo are not resource limited, but majority of you working in AIMS are also not resource limited, but the majority of our country is resource limited. So how do we go about it? And what's your take on this?
Okay, thank you, Dr. Suresh, and it's nice to be here today evening. Thanks to ISCCM. That was a nice question. We may not be resource limited, but there is also a limitation in suspicion and action when it's warranted. So I think what is important is to understand first, as has been beautifully put forth by all the previous speakers, Dr. Prashant especially, the clinical monitoring and when we are worried about a rising ICP. If you can think about instances where the ICP is rising and then triage about the risk-benefit ratio. So, for example, a younger patient who has a long period of life in front of him and he has a TBI who is now starting to show signs of increased ICP, even if the resources are limited, here would be a patient where as an intensivist, we pressurize or force their team to think about the gold standard of ICP monitoring, which could be as simple as putting in an external ventricular drain. If there is pressure from the intensivist and you have an understanding neurosurgeon, or sometimes even intensivists put in the bolts, invasive ICP monitoring is really the best thing to do. There is no surrogate for it. Having said that, we do EVD ICP measurement very frequently in our ICUs, but when that is not possible, or especially in medical ICUs, say a hepatic encephalopathy, if it's not just a traumatic brain injury, if it's somebody with a traumatic subarachnoid hemorrhage, there we're using the non-invasive methods, of which we do not have a pupillometer as of now, but we routinely use the optic nerve sheath diameter, which is very helpful. And various guidelines are now coming up on when to suspect, whether it is more than 5 millimeters, you start suspecting. If there is an increase of more than 0.5 millimeters in serial measurements, then you suspect an increased ICP. So all the guidelines are out there, and that is what we are doing presently, even in resource limited situations. Does that answer your question?
Absolutely, absolutely. I think the key word that comes out, it has to be a part of protocol-driven care in patients who are at risk of elevated ICP, and that is true even in a resource-limited country. So I think as you rightly said, just resource limitation doesn't make my brain not at risk. So I think it has to be part of the protocol-driven care. Whatever be the protocol may be just to use an ONSD, as you rightly said. The protocol may be PbTO2 and dialysis in certain units. And it may be differing, but you need to be a part of the monitoring when you are suspecting that the ICP is going to rise. So we need to monitor it. Very well said, ma'am. I think that's exactly the point that we are trying to make here. Obviously, it's not possible to teach everybody about what is the abnormality in the top right hand and the top left second one. And that's not the purpose here. It is just to give the panel discussion is to give a flavor to the audience about the beauty of neurocritical care and what all is happening in this field. Keshav, this is for you, because this is something which is, as we call, DM question. So let's put it this way and say, do you actually do cerebral auto? Because hyperemia versus what is it, the opposite of hyperemia? So whether that is assessing the ICP, do you actually monitor cerebral autoregulation, and what technology do you use? How do you do it? One quick word.
Cerebral autoregulation has been a very fascinating thing which has been in the neurocritical care for so long, that if it is impaired, this is happening, and that, but actually monitor it at times is very, very difficult. Whatever is said in the basically books, that monitoring PRX, pressure reactivity index, pressure, the basically MX, all those things are right from an ICM plus software or various basically software. They give you a Pearson correlation coefficient and give you in the terms of -1 to +1. But then basically alignment of the monitors with that of your of your software, everything is very difficult to actually do. But we have been doing it with the help of TCD, which is a very important by which we can easily monitor the cerebral autoregulation, and by which we measure the dynamic as well as the basically the static autoregulation can also be measured. So that is the thing. Otherwise, NIRS is also one of the.
I'll ask you to take it
Yes,
forward, because now you're going in the right track of saying we can use TCD and we can use, now how do we monitor brain oxygenation? How do we measure brain flow velocity? I think we'll let you answer that question quickly over the next 3-4 minutes to say, just finish it off as the expert.
Yeah, so the like brain oxygenation is, of course, we can monitor it globally. We have monitors like SGVO2, which is a global monitor, which tells you about how much is being basically the demand supply ratio is basically told by the SGVO2 monitor. It is an invasive, basically we retrogradely cannulate the internal jugular vein and see, and there are fiber optic catheters also available by which you can monitor the continuous SGVO2 monitoring, and it gives you a arteriovenous differentiation. So how much is being, so basically you can derive out, provided you have all the things done correctly, your ABC, your clinical examination, your radiology, those things, basics have been done correctly, and then you are adding up with this multi-modality monitoring to help you what physiologically the differences are happening in the patient. Basically, there is a need of hemoglobin, the oxygenation going down, it can be due to the blood pressure, it can be due to the hemoglobin, it can be due to the oxygenation. So all those physiological parameters we need to get early. And the multimodality monitoring is to act proactively, rather not reactively. Basically, we want that our patient has not deteriorated. We have to catch early in the field, early in the scenario, so that we can catch and find out the physiological derangements and can tackle them early. So like we can monitor the cerebral blood flow with the help of TCD. Of course, we can monitor with the help of other monitors which are static, like CT. The PET scan also can be done, which is a static monitor. But TCD we can do frequently. And it is coming up in a big way in the bedside ultrasound, and other TCCS is also coming up. We can monitor, especially TCD we can know in patients, we can know the vasospasm, we can know the autoregulation. Even non-invasively, we can see the ICP through this TCD. And even the brain death patients, we can do we can see that the patient is having reverberatory or oscillatory pattern. To basically, it can be used as ancillary test in the brain death. So these are the things which we have in our armamentarium and can be used to individualize the care of our patients in the neurocritical care.
So I'll put this question to Swagata and Prashant also, because this is because everybody tends to in neurocritical care tend to use TCD for a lot of purposes. So what is your opinion? How do you use it so that our people who are listening can also understand? Swagata, first you. Muted. You're muted. Swagata, unmute yourself. Yeah.
Yeah, is that better? So to tell the truth, we are not yet using TCD to regularly monitor the ICP. We are still limited to the gold standard indications of cerebral vasospasm and, like Keshav said, as an ancillary for brain because it kind of starts telling you, even as the patient is progressing towards brain death, the waveforms start changing and you start knowing that the systolic diastolic gap is increasing, and then it becomes the typical values. So we're not yet using it for ICP monitoring as such, but it helps you to know the condition of the brain, the pressure reactivity index, the compliance per se. That is what we use it for. And why we don't use it? One of the reasons is the subjective differences. It's always best to have a TCD technician, so to say, one person who would keep repeating the tests and following it up over real time, which we do not have. So I'll leave this question to Dr. Prashant now.
Yeah. both of you have rightly covered the practical aspect of TCD. What we have started using it at our place is to look for the vasospasm because we get a lot of clipping surgeries. So all those patients before they are subjected to theater and post surgery as well. So we do use it for detecting the vasospasm, which is quite a good tool in terms of it gives us an early idea. And this also what I say that it clubbed with a clinical suspicion and examination, it really helps. So for all those vasospasm patients who are already for clipping at our place, we have started using it.
I think both of you put it absolutely right. I think the usage has been more in terms of aneurysmal subarachnoid and probably even non-aneurysmal subarachnoid hemorrhage, and
that is what we are using
to predict delayed ischemic neurologic deficits due to vasospasm rather than to monitor ICP. But that's probably the way it is going, and that we need to pick up that skills very too. Dr. Subbareddy, the thing that we don't do very often, we do this 5 minutes run EEGs. What's your opinion on how to do EEGs? What's the indication for EEGs in the ICU? And then we will break it up. I'll just sum it up because we're already 10 minutes beyond. And I think we had a beautiful, exhausting lecture. So Dr. Subbareddy, the floor is yours.
Yeah. So EEG is one thing which is available in most of the hospitals where there's a neuro department. So this is like widely used by the neurologists, but in the intensive care unit, we use continuous EEG monitoring, not the spot EEG. And EEG is useful in many clinical conditions in the neuro ICU when you're treating seizures and the patient, even after giving anticonvulsants after 60 minutes, the patient is not waking up. Or sometimes we know a recent paper, if you see, the incidence of non-convulsive status even in the medical ICUs is up to 30% of the patients have. So when there is unexplained coma or sometimes even in patients with subarachnoid hemorrhage, the EEG slowing we see much prior than the clinical deterioration. So EEG definitely has a lot of indications in the neurointensive care, even post-cardiac arrest. We know it is one of the most important tool for prognosis. And then we have the malignant EEG patterns we see after post-cardiac arrest, and then we say prognosis is poor. And then nowadays we look at the reactivity of the EEG. Sometimes you see the alpha coma in a post-cardiac arrest, and then we don't know the prognosis is good or bad. And then we check for the reactive EEG. And if there's non-reactivity, again, that comes under malignant pattern and the prognosis is poor. But one thing we have to remember is when you're doing EEG in the intensive care unit, you find a lot of artifacts. So interpreting this EEG with artifacts is one thing which is sometimes is complicated. So we take the neurologist help, but otherwise it's very simple to learn and then identify whether the patient is in delta coma or alpha coma, and then any reactivity, malignant patterns, and it is very easy to interpret, and then it is widely used. And then sometimes during daytime, the EEG missions are busy. We try to hook the patients during nighttime, the continuous EEG, and look for any electrographic seizures, or we have got good control, good burst suppression. And then the bispectral index, that is the most simple version of EEG. And then we use it for the sedation monitoring, anesthesia monitoring. So that is one common tool we are using in the intraoperative period and during even in the intensive care units.
Absolutely. So unfortunately, we don't have the US has a lot of Cerebell and all those technologies where the nurses are calling and then you just do an analysis of the particular fragment. Otherwise, it's impossible to do it. We are all still doing 20-minute, 40-minute EEGs, which are not the way to go forward. Minimum 4 hours is what is required to really pick up a non-convulsive status. And there are certain issues with it. And as I said, if you do a neurocritical care DM, we expect you to go through this over 2 years. So we can't expect to finish everything in 20 minutes here. So I'm going to stop here because we're not going to discuss, for the lack of time, cerebral microdialysis and things. And then stop here and leave it to Dr. Mona Lisa, to wrap it up, I probably have one more slide. I don't know why it's not moving anymore, but that's an indication from the PowerPoint itself. Stop. You are gone well beyond time. So it's not letting me go to the conclusion slide. But once 10 seconds, I think, Prashant, I know what your conclusion is, clinical exam, but I'll still add, please sum it up for the audience. What do you feel is neuromonitoring?
See, neuromonitoring is what you started with. It is multimodal monitoring. So unless we have a multimodal thing, any single tool is not going to help. Yes, please, we do understand what is the pathophysiology behind the patient. And based on that pathophysiology, put your clinical acumen, put your clinical examination to place. Based on the clinical examination result, select your modality, what modality we want to add for the monitoring. And have a multimodal approach, because that approach only give us the trend, the deterioration, and that will be giving us the idea about where the pathology is lying, what is getting wrong with the patient, and from where we need to move ahead. Because if we do a monitoring, any of these technique done once at a time is not going to give us the exact idea what the patient's brain is suffering with. And this is what your summary slide says. So all the monitoring tools, just like a house, so we need the electrical part, we need the airy part, we need the plumbing working, and then we also need to look at the structures.
Request all of you to read this article. Keshav, Subba Reddy, Dr. Swagata, last words, please. I'll hand it over to Mona.
Yeah, I will just add it is the multimodality monitoring is, of course, you have to do the clinical examination and radiology and ABC first. That is the first and foremost thing, and then add the multimodality monitoring to proactively find out what the physiological derangements are happening to your patient and correct them preemptively rather than reacting to that when the deterioration happens. So that is where the multimodality monitoring is going to change the scenario.
Okay, I will just add that I really give a lot of importance to the nurse's observation in this multimodality monitoring. It's innumerable times where an experienced nurse will point out to you suspicions of a non-convulsive status epilepticus. They can usually, pick up things like eyeball rolling or small twitching or a patient ka fluctuating GCS hai. That's the biggest thing you have to pick up instead of thinking ki you're not monitoring the GCS properly. When they start saying the GCS is fluctuating, have a very low threshold to think about a non-convulsive status epilepticus. That's me.
My take will be completely I agree with everyone, clinical examination with more non-invasive multimodal neuromonitoring, considering the multi-drug resistant infections we see. Unless it is required, don't go for invasive monitoring when it comes to the neuro patients in the ICU. Thank you.
All right. Thanks, Mona. All over to you.
So we have a question from the audience. It is open to all the panelists and to you also, Suresh sir. Any way to differentiate between early septic encephalopathy and delirium?
Hemant is there, or I can so encephalopathy, delirium, these are all words which are mutually, what do you say, hand in glove with each other, so they don't have any meaning. So if they are altered mental status, then you have to find whether inattentive. If they're inattentive and it is fluctuating and it is acute in course, it's by definition delirium. If they're encephalopathic and if their GCS is RAS is -4, -5, they're comatose. So you have to then partition yourself and then go. And then the causes will be the AEIOUT. So if you're encephalopathic, then automatically sepsis is going to be there. There are certain biomarkers which are in the fray but not commercially available, which is values of movement. So it is the fact that your arousal and this awareness has to be distinguished, and then your clinical examination has to tell you whether they're delirious or whether they're altered. Encephalopathy may not be an acute brain injury, may be a better term nowadays rather than to use any of these terms. So ABI might be a better term to understand this process than anything else. That's my take. Open to comments.
Thank you. Thank you for that, sir. So on behalf of ISCCM, I would like to thank our speakers, our moderator, and all our panelists to make this a great success. And let's not end the discussion, but make it a new beginning of sharper and more brain-focused approach in critical care. We'll meet again next month. Stay curious, stay compassionate, and keep monitoring what matters. Thank you.
Thank you. Thank you all.
Thank you very much. Thank you.